Welcome to AFMC TV. I'm Robin Ledbetter.
The goal of that is to maximize people's quality of life, right?
You want to make sure that your housing is affordable in your community.
We have to think about vaccines in a way that we haven't thought about them before.
I had a lot of the legislative adults to were very creative.
Down on the floor and play with their kids.
AFMC TV, thanks for watching. Have a great day. Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. And today I have with me Dr. Kimberly Gartman, and she is a family practice physician and an assistant medical director for clinical services here at AFMC. Dr. Gartman, thanks so much for joining us.
Thank you for having me. I'm glad to be here.
So from the primary care perspective, what does integrated behavioral health look like day to day in a practice?
Well, for me, it started, we kind of started doing integrated behavioral health kind of towards the end of my tenure in actual one-on-one patient care clinic. And for us, what it looked like was I went in a room with the patient, saw them. If I picked up on something that was going on mental health wise, like depression, anxiety, something they were struggling with, food insecurity, things like that, we had employed a social worker that was on site, had an office next to mine, and we could just go into her office and say, hey, can you come meet with this patient? We've got these needs. And then we would do what's called a soft handoff. So instead of a traditional referral where you write an order for a referral, the call gets made, or an appointment gets made 2 months from now or however long, she walks in the room and said, either met with them in my exam room or took them to her office and said, did a 15 to 20 minute visit to assist them. And that's kind of how it looked in our office. And then the other component of it was we had case manager assigned to us, to our team, and she would reach out to them by the phone. She might reach out to them before their appointment and see if anything was going on specifically. And then after the appointment, she would reach out and follow up with them and make sure that things didn't fall through the cracks. Because with lots of things in medicine, but especially mental health issues, things fall through the cracks and then people end up not getting the care they need. And so that's kind of how it looked in a nutshell in our clinic.
Why is behavioral health integration, though, essential to primary care right now? You're seeing a lot of behavioral health issues?
Yeah. We have always, but more probably now. It's a stressful time in our world, and we have so much access to digital media and everything. And so things that we might have read in a newspaper before or might have never even known about, we know about instantly all day, every day, unless you really filter it. And so people are struggling financially. And so while we've always seen depression, anxiety, and certain things like that, I think there probably is an uptick of that. And when I was preparing for our conversation, I read a statistic that kind of took my breath away, but also did not surprise me that much from the American Academy of Family Practice, which said that up to 75% of primary care visits include some component of mental or behavioral health.
Wow.
And so you got to be perceptive. You have to, because a lot of times, and especially living in the South, traditionally there was a lot of stigma with mental health issues, and people might not want to tell you about it. You might get an, oh, by the way, as you're leaving, or you might not get told anything at all, and you've just got to be able to read people and understand that something's going on, and just pick up on that. Because we're kind of the first line. And the other statistic that I read that I had known about in the past, but just kind of refreshed my memory, is that people who do seek help for behavioral health issues or mental health issues, depression, anxiety, 56% of them will present to primary care with those. They don't go somewhere else. So we've got to be equipped to handle that. And, primary care physicians, just like every other kind of physician, are pressed for time. We're trying to see a lot of patients in a short amount of time, but also still provide good care. And when you have somebody in your office that you can do a soft handoff to, then it really can make an impact, and you're still really involved in the care. That was another thing that I thought was really important, and probably something you were going to ask about, is that when you refer out to a specialist, if you have a good relationship with them, you're going to hear back and you'll get a note back and all that, but it may be a while. And some issues, you really rather it not be that way. And so for us to be able to work with the social worker and the case manager and others, we could day to day know what was going on and not, violating HIPAA laws or anything like that, or privacy where they've divulged something to the social worker that needs to remain private. But the social worker could come to me and say, hey, I don't know that this medicine's working for them, or maybe we need to pursue something else for this patient. And that way things happen a little quicker and don't get lost over time.
And let's talk how this affects chronic diseases like diabetes, hypertension. And integrated care can change the patient experience and outcomes with those patients as well.
It really can. I mean, imagine if you're really depressed or very anxious, you're not functioning very well, and then you get handed a chronic diagnosis that you've got to manage is overwhelming. And so if we're not addressing the mental health side, then patients are much less likely to deal well with the diabetes or the hypertension. They may feel like they just can't manage it, and so they don't, And then for people that we find that, have financial struggles and things like that, then having this model allowed us to even hand somebody a bag of groceries in our clinic, which was amazing. Or to say, oh, you can utilize a GoodRx, or here's the list from Walmart, or, let me work with you and make sure I get you a lower cost medication so you can manage this. And then the case managers came in there as well, because they could say, how are you doing with checking your blood sugar? Or how's your high blood pressure going? So that and the thing about it is something that just I realized somewhere along the line in my practice, and probably later than I should have, is that we're a whole person. You know what I mean? We're not just physiology. Everything affects everything else. And so if you are having mental health issues, it affects you physiologically. But the reverse is true too. You get a chronic diagnosis of something like diabetes, high blood pressure, lupus, any kind of autoimmune disease, it affects you mentally. People who have chronic pain, we know, struggle more with depression. And so you have to see a patient as a whole person, and all the systems work together, right?
And you mentioned this a bit about how primary care is already stretched thin. So integration really helps improve care without overwhelming providers. Is that something that you're seeing within the primary care community? They're overwhelmed. It's a lot to think about, and this kind of really changes that traditional trajectory of what primary care looks like.
It really can help. I mean, we really can get very overwhelmed and very burnt out, and especially because most of the doctors that I know, we go into medicine because we want to help people, and so we don't want a 5-minute visit. We want to actually listen to somebody, and honestly, that helps people's mental health as much as anything, to be heard, to feel like your provider has your back and is really listening to you and isn't rushing you through. But we also have the pressures of, we have to earn a living, and a good bit of us work for different entities, and so they have guidelines and requirements, which are understandable. And then, we also have our charting and all the other things that happen. We've got to look at labs, we have to answer messages, all those things that happen in a day. And if you have teammates that are in your office with you that you can directly walk up to and go, hey, let's talk about this. And that's one of the things that I forgot to write down, but that I loved that we did, was once a week, we would have a weekly meeting and we would go through the patients that we all shared. So the social worker, the case manager, and the primary care provider would sit down at lunch and go, okay, what's going on with this patient? In that, what do I need to be doing? What are you handling? How do we make sure that we're taking care of them well and not missing things?
So we talked about successes. What are the barriers? What are you seeing that organizations face when attempting or trying to implement these things?
Yeah, it's not an easy task. I mean, we know that it helps, but, just like, most other business models and all kinds of things in our society right now, people are strapped and money matters, and it's hard getting that started. You've got to hire a social worker or a psychologist or whoever your behavioral health care professional is going to be. And then you have to hire the case manager. Well, they can't bill for their services mostly, and so where does that money come from? That's a huge barrier. And, also, I think we can always be resistant to change. You learn how to do something a certain way, and then you're trying to change that, and you don't know if it's going to work, and is this going to take, I will say, as physicians, we also sometimes think, is this going to take more of my time that I'm not going to get paid for? And, I know public perception can sometimes be that we make a lot of money and, we don't care, we just care about, but it's really not true. And for sure not in primary care. You have to think about, okay, I have a family and I want to get to go home at some point. Does this really work? Is this going to be a waste of time? But you have to get patient buy-in. They may be resistant too. You have to have some champion on the team that is in a role of leadership that says, let's at least try, let's see if it could work,
So those that want to do it, want to the first steps, what would you say is a first practical step and maybe metrics that they should focus on?
Yeah, so I think for us, and I wasn't the team lead, so I'm just going by my memory. We first just got together as a clinic and said, we think that this might be helpful. We think this is a need, that we need this to happen. We see our patients struggling, but we can't, as physicians, meet all this need, and so that's how it started for us. And it was like, okay, how could it happen? And then we talked to people in the field that had done it before and had some models. And so we were like, okay, this could work for our clinic. And I can't remember, so I don't want to misspeak, but it seems like we had some kind of funding, like maybe a grant or something like that. So I would definitely encourage people to look for grant money or things like that could help start that. So there are a few ways you can measure it. There are a couple of tools that we use already in primary care to see how patients are doing. So there is a metric or a scale called a PHQ-9, which is a depression measurement. And so you start out with, this is where we started, and then periodically you recheck that. To make sure that you're actually doing anything. If they're not getting better, then you probably need to change what you're doing. You shouldn't just continue doing something because that's what we decided we were going to do and then it's not working. There's also one called GAD-7 that is the anxiety metric. And then some other things that we were doing, and I came over to AFMC before I saw the numbers on this, but some of the studies show that there's actually a decrease in emergency department visits when people are treated more holistically like that. And so I know that was something that we were looking at and measuring. I never saw the final results of that, but we were definitely taking a look at that.
Well, great information. And before we go, if you could offer one piece of advice to a primary care leader, physician, considering integration, what would it be?
Do it. There's got to be a better way to say that, but there are one thing that you should know is that the visits with the behavioral health professional don't need to be long. The studies really show that if they can do a 15 to 20 minute visit on the day when you hand them off, that's really effective. So they don't have to be all tied up. And the behavioral health professional, as long as they're licensed, they can bill for a professional, like a psychological visit code. I'm not saying that right, but a psychological code. And the same day that you can bill an E&M code, that's allowed and perfectly appropriate. So that does help with that part some. And then I think just to be curious and think a little bit about how things could be different and better. I will say that it felt better for me. It certainly helped how I felt as a physician, taking care of my patients. I felt like I was doing a better job. I felt more fulfilled. And the studies actually bear that out, that there's better patient satisfaction and better provider satisfaction when you have an integrated approach.
Dr. Gartman, thank you so much for sharing your insight, experience with this. I appreciate you being here.
It's my absolute pleasure. Thanks for having me.
And that's it for this episode of AFMC TV. Thanks for watching and have a great day.